I would like to introduce our first speaker, who's going to give us an overview of pancreatic cancer. So let's welcome Dr. Seth Gross, who is an associate professor in the Department of Medicine, Gastroenterology.
Well, good morning, everybody. Thanks for joining us today on a cloudy day in New York City. I'm going to spend the next 20 minutes or so to give you an overview of pancreatic cancer. So my goals for the next 20 minutes are to go over the signs, the symptoms, and some of the tests that we use. I'll also go over the staging, because not every pancreatic cancer tumor is the same. And you're going to hear about the different treatment modalities, both chemotherapy and surgery, by some of the other physicians later this morning. So first off, what is the pancreas, and where is it located? So the pancreas is an organ that's important for digestion. It produces enzymes to help break down certain types of food. It's also responsible for making insulin, so it helps control your blood sugar. It actually sits deep to your body, so behind your stomach. So you have your skin, and then underneath your skin in the upper part of your abdomen you have your stomach, and then behind your stomach is the pancreas, sort of sitting on the spine. Pancreas cancer, and this is data from 2014, but I could tell you 2015 and 2016 will be similar, which is that there's about 45,000 cases a year, and unfortunately the majority of patients, because they tend to present late, pass away from the disease, and the 5-year survival is around 6.5%. Someone's lifetime risk of developing pancreatic cancer is 1.5%. Some other statistics, when you think about males versus females, it's fairly equal. And when you put them together, you get your 45,000 cases a year. And when you think about age for pancreas cancer, this is something that's later in life, and the average age for someone getting pancreatic cancer is around 70 years old. What about new cases when we break it down per 100,000 for males, female, factoring in different types of race? White or Caucasian individuals are more likely to get pancreatic cancer than African American or Asian or Hispanic. And the survival trends, if you look back to 1975, going up towards 2011, we've done better, but we're working harder to do even better. So back in 1975, the 5-year survival was about 3%, and in 2006, it's around 7.3%. So this 5-year survival is about 7%, and that's just a reflection of, again, the cancer tends to present late. When someone has symptoms, unfortunately, the disease is somewhat advanced. So what are some risk factors for pancreatic cancer? And just because someone has risk factors doesn't mean that they'll develop pancreatic cancer. So smoking we know is bad for all different types of cancer, as well as some other benign conditions like cardiovascular disease, obesity, personal history of chronic pancreatitis. And what that is that over time the pancreas, from lots of injury, most commonly related to alcohol, or some familial conditions that could scar the pancreas and cause a fibrosis. And in some individuals, they could go on to pancreatic cancer. There are certain hereditary conditions that I'll go over. And then there's something called pancreas cyst, which is just a little fluid-filled, sort of like a little water balloon that grows on the pancreas, and there are different types of pancreas cysts. And some pancreas cysts can progress to pancreas cancer. Fortunately, most do not, and most stay quite small. But we have different imaging studies that we use to follow these pancreas cysts. There's ways to evaluate the fluid inside these cysts to better risk stratify our patients. When we think of hereditary cancer syndromes, there's Peutz-Jeghers, familial breast and ovarian, familial adenomatous polyposis, which is a condition where you develop lots of colon polyps. I think many people are familiar with the BRCA gene, BRCA1 and 2, and there's a slight increased risk for pancreatic cancer in that group. So what about the signs and symptoms? What should people be aware about? When you look at that image in the corner there of the eye, you can see that the white of the eye is really not white in this individual, it's yellow. And that would be a sign of jaundice, which happens when the bile from the liver can't get into the small intestine. And usually it's a very subtle finding where family members might not even notice it because they're around the person, and the patient may not notice it. But it doesn't cause any pain, but just all of a sudden you wake up one day and your eyes and skin are yellow. This occurs when the tumor is more in the head of the pancreas, and I'll show you a schematic of the different parts of the pancreas. Patients that have a tumor away from the head of the pancreas, which means away from the bile duct, they're more likely to have abdominal pain and weight loss. So when we think of what's happening, we have our pancreas here, and this is the pipe of the pancreas that pushes out those enzymes to break down food. But you could see here the piping of the liver sort of all converge. It's sort of like going from street level to a highway, and it goes towards the common bile duct, which is right here. And if a tumor grows in this area, it's going to block both paths, the common bile duct and the pancreas duct. And so what happens is that this bile is unable to get to the small intestine. And what bile also does is that it makes our stool brown. And so what you'll hear people say is that their stools get really light and their urine gets really dark because the bile can't leave the liver. And when we get up close and personal and we think about the different parts of the pancreas, this is the tail of the pancreas, this is the body of the pancreas, and this right here is the head of the pancreas where those important ducts are, both the bile duct and the pancreas duct where they merge. And so this is just an example of a tumor in the head of the pancreas, and you could sort of see already that if there was something growing into where these ducts or pipes empty out, they'll get blocked off, and that's how someone gets a change in their skin and eye color. So again, this is just another example of a tumor blocking the ducts. So what are some signs and symptoms of pancreas cancer? So some of them are pretty vague. You could have weakness, you could have weight loss, anorexia where you don't have a desire to eat, we could have belly pain, and there are normal or rather benign conditions that could cause these symptoms too. We talked about dark urine and jaundice or yellowing of the skin. Some patients get back pain because we talked about how the pancreas sits deep to the body on the spine, and there's a nerve that runs there that could cause some discomfort. On physical exam, I'd see yellowness of the eyes. We may see some fullness of the liver. We could see weight loss, and sometimes patients don't even realize that they're unintentionally losing weight, and their clothes just start to get big. I may be able to palpate or feel something on the abdomen to suggest that there's something going on, and sometimes they could even get a buildup of fluid in the abdomen where they feel somewhat full and distended. The most common type of pancreas tumor that we see is something called an adenocarcinoma, and that's a cell type that the pathologist confirms for us. And cell type is very important, not just in pancreas cancer, but in other cancers as well, because it allows the medical team, and what we do here is a multidisciplinary team where we have the oncologist, the surgeon, the radiologist, the pathologist, and the GI physician when it's a GI-related tumor, all meet and discuss cases to sort of tailor the therapy for that individual. There are other types of tumors called neuroendocrine tumors, which are less common of a pancreas tumor. Again, when we think of the parts of the pancreas, there's the head, there's the body, and the tail. And you can see here that there are some pretty important blood vessels that sort of run next to the pancreas. And this is important because sometimes these tumors could touch or even encase some of these blood vessels, which would alter the course of treatment recommendation. So again, this is just an example of a tumor in the head of the pancreas. So when we think about locations, where do we commonly find tumors? 60% of tumors are found in the head of the pancreas. And when you think about, we looked at the statistics a little while ago about the survival at 5 years is somewhat low. And partly it's because it takes time for a tumor to grow to block off that bile duct for us to notice, or family members to notice, or even the patient to notice that something's going on. But the most common area is the head of the pancreas. So what are some other things that we do? So once we know that someone has a pancreas tumor, we have to do staging. We have to get a better handle on what degree of pancreas tumor that person has. So there are blood tests that we look. So we look at the liver function, something called bilirubin. So if someone's yellow and they can't empty out the bile from the liver, the bilirubin will be elevated. But bilirubin could be elevated if there's a stone blocking the bile duct, say with someone that has gallbladder stones. We look at tumor markers, CA19-9. Tumor markers alone will not diagnose a condition because there are benign conditions where tumor markers could be elevated, but it's really looking at the whole clinical picture. And sometimes after a diagnosis is made and someone's treated, we use those markers to get a set, make sure that that person stays in remission. There's a lot of imaging studies that we could do, such as MRI or CAT scan. Less so ultrasound, it's not as sensitive as the others. And then there are some endoscopy tests that I could do as a gastroenterologist, such as endoscopic ultrasound, where if you've ever had an endoscopy, which is a flexible tube with a camera that looks at the lining of the stomach, we do have scopes that have an ultrasound built in. So if you've ever had an ultrasound on your skin, or if you've gone to your gynecologist that had a transvaginal, I'm able to do an ultrasound from within inside your stomach and really get a good look at the pancreas. There's laparoscopy, where the surgeon may go in to look at inside the abdominal cavity to just make sure that the tumor is localized to the pancreas. And then, of course, many of these modalities could offer biopsy, which is tissue diagnosis, so we could get a sense of what type of tumor and then come up with the treatment plan. So when we think of elevated CA19-9, this is a tumor marker that we could see in different cancers. In addition to pancreas, we could see it in biliary cancers, liver cancer, even stomach, ovarian, colorectal. But we see it in benign conditions too, from an inflammatory response, something called cholangitis. And that just means that the liver is being blocked off, say, by a stone from the gallbladder, and the person could get an infection up in the liver, and it could cause this blood test to get elevated. So what are some of the different radiology tests? I would say ultrasound is the least expensive test, and sometimes it'll come across a pancreas tumor, but it's not very sensitive, and when we're suspicious of a pancreas tumor, we'll probably send someone for a CAT scan or MRI. CAT scan is certainly more sensitive than an ultrasound, and it's good for looking at tumors, 2 centimeters or even less than 2 centimeters. And we also have MRI, which is another way. And MRI and CAT scan, if you're familiar with Google Maps, I look at those as that 30,000-foot view, of what's happening within the abdominal cavity. And when you do street level views like endoscopic ultrasound or ERCP, you're getting just an up close look and a different vantage point. And together, the information from all these tests really gives us a sense of the staging of a tumor to give the recommendation of should someone go straight for surgery, or should someone get chemotherapy and medications to shrink the tumor and then get reconsidered for surgery at a later time. So what about some of these endoscopy tests? There's something called ERCP and EUS, and they offer different things. ERCP years ago was used as a diagnostic and therapeutic tool for, say, pancreas tumors, but now it's mainly used to help decompress and put a little stent, and think of it as a little pipe across an area of the bile duct that is blocked. And so what you're seeing here is that we have a scope coming into the stomach. It goes into the duodenum, which is the first part of the small intestine, and all of these areas are by the pancreas. And what this instrument is able to do is to slip tools up into the ducts, one to get tissue if we need it, but more importantly, to take the pressure off the ducts of the liver that are getting blocked, and allowing the patient to drain the bile, so one, that they don't get infection, and then the other thing that the person will notice over the course of several days, that yellowness that they had will go away. And this is just another example of the scope accessing the ducts of the liver to put that stent in. And we use X-ray imaging for this, so we could see the stent being placed. This is the bile duct, which is somewhat dilated, and it's dilated because there's a tumor here. So there's this back pressure that causes the duct above it to be stretched. And by putting that stent in, that'll decompress the duct, and it'll allow the fluid from the liver, the bile, to empty out into the small intestine. So what's the sensitivity? It's about 92%. Specificity is 96%, and these are statistical measures of accuracy. So when we do a test for someone, we really want to make sure that we offer the test that's going to give us the most information. So we want something that's really sensitive. But in terms of detecting a malignancy or cancer when we're very suspicious, endoscopic ultrasound is a more sensitive tool than this ERCP test alone. And so essentially what endoscopic ultrasound does is that it also is a scope. And right here at the end of this scope, there's an ultrasound probe. And when we turn it on, we're able to scan the pancreas, so the entire pancreas, looking for the area that's abnormal. And just for those of you that are not familiar, and you have to watch a lot of these and do a lot of these to better understand, but you see all this bright area here. This is a normal part of the pancreas, but then you see this dark circle, and that would represent a tumor, and that would be the target area to stick a very thin needle to gather some cells for the pathologist to help give us a diagnosis. This again is another example of a tumor in the pancreas, and the surrounding is all normal. Other things that we look for with endoscopic ultrasound is the blood vessel involvement to complement MRI or CAT scan when we do initial staging. Now, some patients with a pancreas tumor, they could present with some terrible pain because there's a nerve that's near the pancreas, and it could be very uncomfortable for patients. And so aside from offering pain medications to try to decrease the pain, we're actually able to do a nerve block. So if you've ever gone to pain management, if you herniated a disc, sometimes they'll have you get an epidural. We could do something to sort of stun the nerve and destroy the nerve to decrease the pain that could be caused from a pancreas tumor, to give a patient better quality of life and be comfortable as they go through the treatment process. And I mentioned earlier about using ERCP to sort of introduce a stent, and you see this right here. It looks like a wired fence, and essentially what it's going to be able to do is it's going to open up this area that's getting pushed on. So this is tumor here, this is tumor there, and then the bile duct is getting compressed, and you see that it's narrow compared to the rest of it. When we put this stent in, it opens everything up and it allows things to drain. And it allows us a little time to get things organized for the treatment plan, and we don't have to worry that the patient's going to develop an infection in their liver. So when we talk about CAT scan, and this is just an example of a tumor that a radiologist would see in the pancreas. And this is just another view. So there's different cuts that one could look at a CAT scan. And this is one view, and then there's another cross-section type view that we could do. And you could see the liver, you could see the heart. You see there's a lot of organs, near the pancreas. So it's a very crowded area. So when a surgeon goes in to do this work to remove this tumor, it's very intricate and very detailed. And they really have to watch not to disrupt the other organs, and you'll hear about the surgical techniques in a little while of how they're able to, in some cases, cure pancreatic cancer when it's caught early enough. But again, this green circle represents where there's a pancreas tumor surrounded by all these other structures. So you're talking about blood vessels and other organs. Now, some patients, or most patients, after they have a diagnosis of cancer, we'll send them for what's called a PET scan. And a PET scan is a full body scan that we do, and it allows us to see if the tumor is just localized to that particular organ, and in this case, the pancreas. And so what you're seeing here is that you see some uptake in the center of the abdomen, which is the pancreas, but fortunately the lungs look good and the liver looks good to suggest that this is really localized, and that puts that patient in a better position to go for surgery. Now, there's different components of staging for pancreas cancer, and this goes for other cancers as well. So you may hear this term TNM. T is the tumor itself, and we look at size and how it involves other structures where the tumor is growing. N is for lymph nodes, so we look to see if there's lymph node spread. Now, sometimes we'll see enlarged lymph nodes on a CAT scan and MRI, but it's just inflammation from what's happening, and then the PET scan will be negative. And M means metastases, which means that the tumor may have spread to another organ. So for pancreas cancer, it could mean it spread to the liver. And so when we think of stages, The lower the stage, the more likely the person could go for a curative surgery. And so when we think of T1, it just means that the tumor is less than 2 centimeters and it's sort of sitting in the pancreas, and there are no lymph nodes and there's no spread to other organs. T2, the tumor is getting a little bigger, so it's over 2 centimeters in size, but still, limited to the pancreas, so it's still felt to be early stage. When we go to stage 2, the tumor is getting bigger, so it's T3, so that means it's starting to invade surrounding structures. So maybe it's starting to invade the duodenum, which is the part of the small intestine right near the pancreas, but it still has spared some of the big blood vessels that you see going right behind the pancreas. And then when you get to a stage 2B, it means that they may see on some of the imaging studies a lymph node. That could mean that the tumor cells have started to leave the pancreas and started to drain into this lymph system that we have. And then T4 would mean that the tumor has really started to grow beyond the pancreas, but also starting to encase and touch upon these blood vessels. And this is just an up-close view of the last image, showing how these tumors could really spread locally. And this is important because depending on the stage is going to determine what the team recommends for the best step in initial management. And stage 4 is where the tumor has spread to other organs or just within the abdominal cavity. And it's really important to know the accurate stage because the last thing we'd want to do is put someone through a big surgery or give them chemotherapy, and it wouldn't be helpful for their treatment. And when we look at the statistics, just like with other cancers, the earlier the stage, the better the outcome. So if someone is stage 1, the survival at 5 years is around 20%, but when you get to stage 4, it's less. It's under 2%. So just some take-home messages. I think that one, it's really important that everybody knows their body. And if you're not feeling well, it's so important to go to the doctor. It doesn't mean you have cancer. You could just have something else. But thankfully, most things in medicine today are very manageable. If you have a family history of pancreatic cancer, you may want to go to a genetic counselor. We don't have really great screening for pancreas cancer like we do for, say, breast cancer or prostate cancer or even colon cancer where we do colonoscopy. You may hear or personally have a pancreas cyst. And depending on the type of cyst and how large the cyst, this is something that we just need to keep a close eye on. And fortunately, most of the cysts really don't go on to progress to pancreas cancer. And again, if you see symptoms of some of the things we talked about, in a friend or family member, or even yourself, certainly, don't sit on it. It's always better to get checked out and for us to send you home versus, waiting several days, weeks, or months before seeing your doctor. So thank you for your time. I'll be here at the end for questions.